very good morning to everyone. Thank you for joining for today's breakfast at UMHealth. I myself, Krishna here, will be moderator for the first session for today. All right. Before move on, I'm basically the head of the CRL, and I'll be sharing a short video to give an introduction. Before that, I would like to introduce the speaker, which kindly accepted to present her work, which been conducted in our cell culture lab under the umbrella of CRL, Central Research Laboratory, Dr. Ngoi Tein. She's a molecular microbiologist with a PhD um, from University Malaya, research on bacterial epidemiology from and a genome's underlying severe human and animal infection. She also investigates human microbiome dynamics in relation to surgical outcomes and reproductive health, contributing and actively to infection epidemiology and antimicrobial resistant and translational microbiome research. So thank you, Dr. Tein, for your willingness, your kind willingness to present your work that been conducted, I believe, for our last 2 years under the cell culture facility in CRL. All right. Before move on with the presentation, I would like to share a short video of the CRL to introduce our facilities. Thank you for watching the short video about CRL. I just want to highlight that Central Research Laboratories, which have facilities and covers various equipments related to proteomics, genomics, cell culture, readily available for the stakeholder from the Faculty of Medicine. lecturers and students, and also external users. So please approach us. Just browse CRL FOM, and then you can know the facilities available under the CRL. All right. Without further ado, I just like to introduce the title. I mean, the project that Dr. Sutin would like to present. Is a genetic mechanism and correlated risk factor of antimicrobial resistant ESKAPEE pathogen isolated in a tertiary hospital in Malaysia. Dr. Sutin, the floor is yours. Thank you.
Thank you, Dr. Krishna. Good morning, everyone. Thank you for the invitation for me to share my work here today. Many thanks to CRL in supporting my research, especially on the lab works. So for today's presentation, I will focus on three main questions, which are the resistance phenotypes that were present in the ESKAPEE pathogens, which genetic determinants that explain the resistance, and also which resistance profiles that were associated with hospital-acquired infections. So a bit of introduction on the work. Antimicrobial resistance phenomenon remains a major threat to public health worldwide. So the global emergence and the spread of resistant organisms is often associated with treatment failure, adverse clinical outcomes, higher mortality, and the greater need for intensive care. So what is of particular concern are the multi-drug resistant organisms, also known as MDROs, which are non-susceptible to multiple antimicrobial classes. So their impact is not just confined to hospitals. It extends across human health, veterinary practice, agriculture, and the wider environment. So in response to this AMR threat, the World Health Organization has published its first bacterial priority pathogens list in 2017. So the purpose of this classification was to direct the surveillance, research, and antibiotic development efforts towards organisms for which the clinical need was most urgent. So this 2017 priority pathogens list was organized into critical, high, and medium priority organisms. The list particularly highlighted the multi-drug resistant gram-negative organisms that pose a particular threat in hospitals, nursing homes, and among patients whose care requires devices such as ventilators and blood catheters. So this includes the ESKAPEE pathogens. These ESKAPEE pathogens are listed as organisms of critical importance due to their multi-drug resistant nature and increased resistance to the last resort drugs, which consequently require urgent development of new antibiotics. So building on the 2017 edition, the 2024 WHO update has broadened and refined this framework to 24 pathogens across 15 families. But it retained a strong focus on gram-negative bacteria that are resistant to last resort antibiotics, drug-resistant Mycobacterium tuberculosis, and also other high-burden resistant pathogens such as Salmonella, Shigella, and so on. So while considering the burden, transmissibility, treatability, and prevention options of these AMR pathogens. Antimicrobial resistance is actually a natural evolutionary phenomenon. Mutations and genetic exchange can arise at low frequency all the time, but the antimicrobial exposure creates a selective pressure. Susceptible bacteria are removed from the population, while organisms that carry advantageous resistance determinants will survive, multiply, and become enriched in the population. The process of AMR emergence, dissemination, and the persistence among bacterial populations is often accelerated by antimicrobial overuse and misuse in healthcare settings, livestock production, and also in the aquaculture industries. Human, animal, and environmental microbiomes will then act as reservoirs in which the resistance genes can spread by horizontal gene transfer, both within and between bacterial species. So this is clinically important because organisms such as the Escherichia coli, Klebsiella pneumonia, Enterobacter species, and Enterococci, which may begin as relatively harmless intestinal commensals, but yet they were able to acquire resistance and subsequently cause healthcare-associated infections. These healthcare-associated infections are acquired during the course of care and they are not present at the time of admission. So based on WHO data published in 2011, the historical data, the hospital-wide prevalence of HCAIs in Malaysia was rated at 14%, twofold higher than our neighboring countries. Hospitalized patients, particularly those who are in critical care, they often have severe underlying disease, impaired immunity, and repeated exposure to invasive devices. So the empirical broad-spectrum therapy can further select resistant subpopulations, making the subsequent infection more difficult to treat and control. So molecular surveillance actually adds value when it links the three aspects or three layers of information: the resistant phenotypes, the underlying genetic mechanism, and the host or the clinical context. So this linkage can actually help to detect emerging pathogen lineages, monitor the transmission and resistance trends, anticipate cross-resistance, and support treatment and infection control decisions. It also generates the mechanistic evidence that we need to guide further diagnostics and therapeutic development. So our first objective was to characterize the phenotypic and genotypic features of drug-resistant ESKAPEE pathogens to identify the AMR trends and molecular epidemiology of these organisms. We then associate these microbiological findings with patient and clinical variables so that the results could provide practical insight for rational antimicrobial use, surveillance, and infection prevention strategies in Malaysian hospitals. We prospectively collected 378 non-duplicate clinical bacterial strains at the UMMC over 9 months from October 2019 to July 2020. So the study used convenient sampling method with 54 isolates representing each of the 7 ESKAPEE organisms. All the selected bacterial strains were resistant to at least one antimicrobial agent. The identification was performed by conventional culture and by tag at the diagnostic lab, followed by species or genus-specific PCR confirmation at the research lab. The susceptibility was, antimicrobial susceptibility was assessed by distribution and broad microdilution method to determine the minimum inhibitory concentrations of the selected antimicrobial agents. Targeted AMR gene profiles of the non-susceptible strains were then examined by PCR and DNA sequence analysis. So an infection was classified as hospital-acquired when the signs of infection and a positive culture occurred at least 48 hours after admission. So we then followed by a forward stepwise logistic regression to correlate the AMR profiles and the clinical data to determine the potential risk factors associated with hospital-acquired infections. The baseline data of all ESKAPEE strains collected are summarized in this table. All organisms except E. coli were predominantly associated with hospital-acquired infection. The highest proportion was observed for Acinetobacter baumannii, followed by Klebsiella pneumonia. And in contrast, the E. coli strains were half of the E. coli strains were community-acquired. So the specimen patterns also differed by organisms. Enterococci, Klebsiella pneumonia, and E. coli were commonly recovered from blood, urine, and other body fluids, while Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter were more commonly recovered from respiratory specimens. Most bacterial strains originated from medical wards, but Acinetobacter baumannii was most strongly represented in critical care, so where half of it were isolated from ICU patients. The MDR burden was also concentrated in 4 organisms, namely the Acinetobacter baumannii, Klebsiella pneumonia, and Staph aureus, and E. coli. So next we will go into the individual ESKAPEE pathogens. Within the enterococcal collection, Enterococcus faecalis and Faecium accounted for majority of the enterococci strains. We observed that 39% of the enterococci showed high-level aminoglycoside resistance, with unique resistance genes profiles that are different from other enterococci, isolated in the Klang Valley. So this may indicate a different lineage, different lineages of aminoglycoside-resistant enterococci, which develop resistance through a separate evolutionary pathways. We also observed 6 vancomycin-resistant enterococci. Most of them came from blood or bone specimens, highlighting their invasive potential. The prevalent vancomycin-resistant gene identified in our enterococci strains collection was VANC-B gene. So this differed from earlier Malaysian reports in which VANC-A was more common among the enterococci strains in Malaysia. This observation suggests a possible local shift in the dominant VRE genotype from VANC-A towards VANC-B. But however, this remains a surveillance signal rather than proof of regional replacement of the genetic dominance. So of course, this requires further confirmation with a larger multi-center sampling. The Staph aureus collection was dominated by methicillin-resistant Staph aureus, MRSA, 65% of which were hospital-acquired and 80% of the MRSA strains were multi-drug resistant. We also observed community-acquired MRSA in 28% of the strains, most of which were also multi-drug resistant. This indicates that the resistant clones were not only confined to the hospital settings. All Staph aureus strains remain susceptible to linezolid, rifampicin, and vancomycin. However, we observed 40% of the strains had a vancomycin minimum inhibitory concentration of 1 microgram per ml. It is still within the susceptible range, but it is worthy of surveillance as it may potentially lead to the emergence of heterogeneous resistant strains. Inducible clindamycin resistance was common. All the erythromycin resistant strains carried the ERMC gene, but because the inducible clindamycin resistant phenotype can appear as clindamycin susceptible in routine lab testing, so the failure to detect it may result in subsequent therapeutic failure. The ERMC predominance among our strains also differed from the previously reported MSRA-mediated resistance observed among the Staph aureus isolated from east coast of Malaysia, suggesting a distinct lineage of erythromycin resistant which coexisted in this region. So Acinetobacter baumannii showed the most concerning overall profile actually. So 94% were hospital-acquired, half of which were isolated from ICU patients, and 69% came from respiratory specimens. Almost 90% were multi-drug resistant, and all strains showed resistance to imipenem. So they are all carbapenem-resistant Acinetobacter baumannii. So therefore, the entire collection, the dominant beta-lactamase genes detected among these carbapenem-resistant strains were BLA OXA23, OXA51, and also the BLATAM genes. So we also observed 4 strains that carried the BLA VEB gene. All 4 came from ICU patients with hospital-acquired pneumonia. Because this BLA VEB producing Acinetobacter baumannii had mainly been reported in Europe and the Middle East, the detection of these strains in Malaysia may have been reflecting a clonal introduction or a genetic exchange between the local and the global strains. We also observed colistin resistance in 19% of the strains, which further narrowed an already limited therapeutic option for the treatment of carbapenem-resistant Acinetobacter baumannii. So this table shows how frequently the major beta-lactamase genes co-occurred among the Acinetobacter strains. The repeated co-occurrence of these genes supports the circulation of characteristic resistance genes profile in this setting, And it is also consistent with the very high level of beta-lactam resistance observed among the strains in this study. The next, Pseudomonas aeruginosa presented different patterns from Acinetobacter, although 63% were hospital-acquired and 56% came from respiratory specimens. They were mostly non-multidrug resistant, but nevertheless, resistance to the key first-line antibiotic classes such as amikacin, ciprofloxacin, ceftazidime, and carbapenems remain clinically relevant among the Pseudomonas strains. The AMPC beta-lactamase gene was detected in majority of the cephalosporin-resistant strains. So the organisms that produce this beta-lactamase enzyme are often associated with significant morbidity and mortality. Compared with the UMMC study conducted almost 10 years earlier, the resistance rates among the Pseudomonas aeruginosa had shown a marked reduction over the years. So this is compatible with the beneficial impact of antimicrobial stewardship program in place. But our study alone, of course, cannot establish a cause-effect relationship. The clonal turnover of the bacterial strains, genetic mutation, and horizontal gene transfer may have also contribute to this fluctuation over time. So the enterobacterial component included 54 strains each of the Enterobacter species, Escherichia coli, and Klebsiella pneumonia. Hospital acquisition predominated in Enterobacter species, Klebsiella and Klebsiella pneumonia, whereas E. coli was more frequently associated with community infections. MDR was common in Klebsiella pneumonia and E. coli, but much less common in the Enterobacter. Clinical strains of the Enterobacterial organisms in Malaysia actually have long been known to share plasmids and other mobile genetic elements which allow resistance genes to circulate across the species within the same ecosystem. So the bar chart here highlights several clinically important characteristics of the Enterobacterial strains. Both E. coli and Klebsiella pneumonia show high rates of non-susceptibility to cephalosporins, amoxicillin clavulanate, ciprofloxacin, and trimethoprim sulfamethoxazole. Klebsiella pneumonia also show higher rates of resistance to piperacillin tazobactam and carbapenems than the other two organisms. So in contrast, amikacin remained active against almost all of the Enterobacterial strains in this study. Colistin resistance was highest in Enterobacter, and the high rates of amoxicillin clavulanate and quercetin resistance in the Enterobacter species were anticipated due to the intrinsic resistance nature of this organism. So overall, our results show that Klebsiella pneumonia carried the broadest acquired resistance burden, while colistin resistance was already emerging across all three organisms. The minimum inhibitory concentration, MIC data here, show the intensity of resistance within the non-susceptible subsets of the Enterobacterials. So carbapenem-resistant strains from all three organisms had high MIC values, indicating that at least 50% of the non-susceptible strains were highly resistant to these agents. So non-susceptible E. coli showed similarly high level of resistance against ciprofloxacin and the carbapenem, while the carbapenem-resistant Klebsiella pneumonia show a very high level of imipenem resistance. Colistin-resistant Enterobacterials had MIC 50 values that range between 8 to 32 microgram per mil, but bear in mind that these values do not represent the entire species collection, but only describe the Enterobacterial strains that are already classified as non-susceptible in this study. But even with that notion, the findings indicate a high level of resistance and an emerging colistin resistance problem among Enterobacterials. Klebsiella pneumonia carry a substantially more diverse beta-lactamase genes than E. coli. The co-circulation of this Klebsiella pneumonia strains carrying multiple beta-lactamases with the other Enterobacterials in this region actually creates a favorable conditions for horizontal transfer of cephalosporin resistance. So our local data comparison also suggested there's a shift in carbapenem-resistant Klebsiella pneumonia from an OXA48 dominant population towards NDM since 2013, which is very important because NDM-containing strains often show a much higher level of carbapenem resistance. So for fluoroquinolone resistance, we examined both chromosomal mutations and plasmid-mediated QNR genes. In ciprofloxacin resistant E. coli, the major chromosomal mutation hotspots were at the gyrase A and the topoisomerase 4 PARC gene. We also identified two previously unreported gyrase A mutation here. But these observations are simply based on DNA sequence analysis and would therefore require further validation to establish their individual contribution to fluoroquinolone resistance. The plasmid-borne QNRB and QNRS genes were detected across all three enterobacterial groups, with the highest QNRB frequency in Klebsiella pneumoniae and the highest QNRS frequency in Enterobacter. The overall fluoroquinolone resistant patterns appears to be a combination of chromosomal mutations and transferable QNR genes rather than conferred by a single resistant mechanism. We next looked into which AMR features were associated with hospital-acquired infections. Okay. Four resistance profiles actually showed increased odds of hospital-acquired infection in the final regression model. So across the organisms, the consistent biological theme here was beta-lactam resistance, although for Staph aureus, this was expressed as methicillin resistance. So but again, these are associations, not a proof that this resistance actually caused hospital-acquired infections. But clinically, these findings could support a coordinated review of the beta-lactam use, local antibiogram screening and isolation policies, device care, infection control, and molecular surveillance. So overall, our findings provide some insight into the microbial resistance patterns and the risk factors of the ESKAPEE-associated hospital-acquired infections. So this information may contribute to make better informed decisions on appropriate prescription plans and infection control strategies. The key takeaway messages are MDR is a common phenomenon among ESKAPEE organisms. There are emergence of new AMR lineages, and we observe some dominant shift in the AMR genotypes. And we see emergence of community-acquired MDROs. And of course, last but not least, the useful information often comes from integrating the phenotype, genotype, and patient context. Okay, so I will stop my presentation here. Thank you very much for your attention.
Thank you, Tein, for such an interesting talk. I believe this talk is be very useful for the hospital-associated infection management. All right, so now the floor is open for Q&A. Right, Dr. Tein, I have very simple questions. My background is not the microbiology, and I try to understand all the jargons that you presented. And I'm glad that you've done the research under CIMBL and collected a lot of data for presentation. Thank you very much. All right, my question is, so you basically noted a significantly higher frequency of extended spectrum and metallo-beta-lactamase genes compared to, the published report. So what factors do you believe are driving this rapid genetic divergence or disseminations with the specific, hospital setting like UMMC?
Okay. So yeah, actually, to answer your questions, of course, the what we know so far is the frequent use of this kind of like broad spectrum beta-lactams antibiotics actually will select for the resistant strains. So that probably explains why the core occurrence of these multiple beta-lactamase genes within the same organisms and so on. But yeah, so for the strains that are included in this study, it may be a bit biased. So we shouldn't thinking that the beta-lactams resistance, multiple beta-lactams resistance is very common among the strains isolated in UMMC. No, but that was because we were only focusing on drug resistance ESKAPEE during our sample collection.
All right, thank you very much. So those who are facing challenges, to manage, infectious disease, please approach Dr. Tein. Anyway, Dr. Tein, we hope that we continuously support your research, under the CRL facility. Thank you very much. I close the session and welcome the next session. Thank you very much.
Thank you, Dr. Krishna. Thank you, everyone.